Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Hello and welcome. Dr. Mohammed AlSheef, your host of Elixir of Life, is kicking off another inspiring and informative episode with our distinguished guest to explore new frontiers and bring you most up-to-date information related to health. Our topic tonight is very interesting and juicy. We'll be talking about stroke rehabilitation. Besides that, we have other inventive and stimulating segments. Stay tuned for a special episode. We will start with the first segment, Quote of the Week. To watch more details about this report, stay with us. Once again, welcome back to Elixir of Life. Our second segment will be our episode theme. We'll be talking about stroke rehabilitation. Stroke is one of the leading causes of long-term adult disability in Saudi Arabia. Early and effective rehabilitation involving multidisciplinary team can improve functions and sometimes remarkable recoveries for someone who suffered a stroke. It's my honor and pleasure to welcome my distinguished and esteemed guests, starting by Dr. Ahmad Al-Qureshi, consultant and head of Department of Physical Medicine and Rehabilitation. Welcome, Dr. Ahmad.
It's a pleasure to be here. Thank you very much.
Okay, and also my pleasure to welcome my second guest, Mr. Faisal Al-Dubian, physical therapist from King Fahd Medical City.
Thank you very much. It's a pleasure to be here with you.
Okay, without further ado, we'll start by asking the first question for you, Dr. Ahmad. What's stroke and how common stroke in Saudi Arabia compared to the international figures?
Thank you very much for this important question. There are a lot of misconceptions about stroke in general public, so I would like to explain and try to answer this question with the help of this brain model. Stroke is actually a disease in which there is disruption of the blood flow to a part of the brain. So for example, if that is the blood vessel, there could be disruption in the blood flow to the part of the brain because of a clot or
yes.
because of bleeding inside the brain. So that's pretty much, in summary, how we can explain stroke. For example, if there's a clot over here, part of the brain which is being supplied by this vessel or blood vessel can be affected. And the part of the body which is being controlled by this part of the brain can be affected as well, which can cause, in common words, weakness of the shoulder, arms, speech, or leg as well.
Excellent. That's very beautiful. Thank you, Dr. Ahmed. Asking the second question, what's post-stroke rehabilitation?
Great. Before we move on to stroke rehabilitation, I would like to clarify the concept of rehabilitation, because rehabilitation is pretty much poorly understood in many parts of the world, especially in Saudi Arabia and in many developing countries as well. Rehabilitation overall is a process which deals with improving the quality of life and function of individuals with disability. In many areas of the world, people believe that rehabilitation is only physical therapy, or rehabilitation is probably rehabilitation of drug addicts, or rehabilitation is probably nursing care, or there is a new terminology that is being perceived as rehabilitation is pertaining to disability or disaster relief, I would say. So in the contemporary world, rehabilitation is a process which is empowering the patients with disability.
Excellent.
So rehabilitation medicine is actually a part or a branch of medicine which deals with improving the quality of life and function of patients with disabilities. The contemporary model of care is called rehabilitation team or interdisciplinary rehabilitation, in which rehabilitation physicians or physicians who are involved in the care of patients with disabilities or stroke patients, they work alongside different disciplines of rehabilitation.
Excellent. So we will be talking about the role of multidisciplinary team, but you brought very important point that rehabilitation is subspecialty of medicine, and underlying it stroke rehabilitation, and what other subspecialty of rehabilitation?
Great. If we talk about subspecialties of rehabilitation in general, it could be related to spinal cord injury,
traumatic brain injury,
amputee rehabilitation, pain and muscular disorders, rheumatological diseases, patients with limb loss rehabilitation as well, patients with multiple sclerosis, brain tumors, spine tumors. The upcoming and booming specialties are cancer rehabilitation and cardiopulmonary rehabilitation. These are a few, to name a few.
Oh, so it's a broad, subspecialty, and you have subspecialization inside, rehab medicine.
Absolutely, absolutely, and it's one of the upcoming specialties and booming specialties in the field of medicine, especially for physicians who are exploring interesting and challenging specialties. And it has become one of the comparative specialties in Saudi Arabia, especially in the Saudi Council as well. So there are like multiple hospitals taking up the specialty and running residency programs.
I'm glad, Dr. Ahmad, you brought that misperception about rehabilitation medicine. They think rehabilitation is equivalent to physical therapy. That's important that you brought this one. I think this is very common misconception and misperception. This bringing us that what is the role of multidisciplinary team in rehabilitation medicine? Okay.
Absolutely. So the contemporary model of care is called interdisciplinary rehabilitation, in which rehabilitation medicine is one of the lead roles, or physicians who are taking care of the patients, who are in charge of the patients. Alongside, there are other disciplines, including but not limited to physical therapy, occupational therapy, art therapy, recreation therapy, interestingly music therapy and pet therapy as well. Then there is speech therapy, swallowing therapy, audiology, and then there are experts in prosthetics and orthotics, and there are experts in assistive technology, specialized rehabilitation nursing care, social workers, case managers, health educators, nutritionists, and psychologists, and we have spiritual and religious counselors as well.
So big.
Yeah, so basically there are like almost 15 to 17 experts who are trained, who are educated. They have spent like 5 to 10 years of their career in training or gaining experience before they start off their services for these patients. Yeah.
Excellent, very beautiful. So part of that team is physical therapy. So would like you, Dr. or Mr. Faisal, to highlight the role of physical therapy in rehabilitation.
Yes, from physical therapy side, the physical therapy, they treat the problem related to the problem related to stroke, for example, like the balance and the movement and the coordination. So if the patient have problem like the problem in the balance or the coordination, so this will result with maybe some abnormality in the ambulation or the walking, sorry. It might cause like limitation in his function, daily function, like the walking and the using the stairs, or even for the transfer sometimes from the bed to the wheelchair. So it will cause difficulty for the patient or for the stroke patient. So our role to improve the function, as I said, for the ambulation and all of these daily functional.
Excellent. Mr. Faisal, physical therapist is specialty per se, and there is subspecialty of stroke physical therapist like you, okay?
Yes, there is subspecialty for the stroke, and as you said, Dr. Ahmad Qureshi, for the SCI, spinal cord injury, and for the traumatic brain injury, even for the pediatric.
And for you, you are specialized
in the stroke patients.
Stroke rehabilitation.
Yes.
So what's the difference between physical therapy and occupational therapy for stroke patient? Okay.
Yeah, actually there is it's
big difference. Huh?
There is difference, yeah, but there is something related. It's common for the PT and the OT, or for the physical therapist and the physical therapist and the occupational therapist. We deal with the patient, for the stroke patient, like they see, or the OT, they assist the patient with the disability, like
Eating, writing.
Yeah, for the example, for like the grooming, feeding, toileting, they assist all of these the function, يعني, and they see what they can do with the patient. يعني, they might provide for the patient wheelchair, and they might provide like some specific equipments to help the patient how to.
Thank you, Dr. Faisal. So, Mr. Dr. Ahmed, what disabilities can result from a stroke?
Yes, I think this is one of the concepts which need to be conveyed to general public, because usually there is a perception that once a stroke has happened, that would or that may only affect the arms or legs. But if you look from head to toe, talking about the mental abilities and physical abilities, let's say the thought processing, which in technical terms is called cognition, is affected or can be affected as well. Then there is language can be affected. Language is perceived as, is one of the impairments is called aphasias in language, which is an inability of comprehension and processing and expression of information. Not only that, 30% of the patients can have problems related to mood and personality. They can have depression, which the general public or the family around the patient may not understand what's going on. Then 30% of the patients can have vision-related problems as well. Similarly, 50% of the patients can have problems in their speech. And then 90% of the patients, they usually have weakness of extremities of arms and legs. Patients can have loss of control of the bladder and bowel too, and they can have 30% can have pain in the muscles and joints, which is very agonizing for the patients. One of the things which is not often understood is the concept of spasticity. Because the brain loses its control over the tone of the muscles. So there is a sustained contraction of the muscles as well, which is called spasticity, which can be pretty disabling, and we may see some of the stroke patients with unusual posturing of the hands and that might be due to weakness plus a combination of spasticity as well. So this is, these are the physical impairments, physical and mental impairments related to the body of the person. Rehab goes far much more and beyond that, because rehabilitation is about biopsychosocial empowerment.
Very important.
As clinicians, most of the times we are dealing with the biological aspects, the clinical aspects, or the physical and mental aspects as well. But if you translate that into function, stroke can cause a lot of activity limitation, which is also called as disability. We don't encourage the word disability a lot because it can be stigmatizing in many setups. So the alternative word is activity limitation, which we are training our graduates and colleagues to be more proactive, especially when we're dealing with the patients, to avoid this terminology. And the third component, how this functional impairment translates into the society, is called handicap. For example, if a person has weakness of the hand, this is an outcome of the stroke. This is called an impairment. If that person who happens to be a teacher or a computer operator may not be able to do typing, right? So that's a kind of disability which can be converted into, which can be understood as a handicap, because he will not be able to go back to his work. So as rehab clinicians, we look far much more beyond just the weakness of the hand. Because usually the goals of the patients are not a hand function recovery. They're thinking of the recovery and participation in their social role.
Consequences, and implications, Thank you, Dr. Ahmed. We'll go for first report. Watch more details about this report. Please stay with us.
Hello, in this health sketch we want to talk to you about stroke. The word stroke comes from the idea of receiving a strike or blow, as that is how quickly strokes appear. All of a sudden, people are struck by this illness. Did you know that every year more than 15 million people worldwide have a stroke? Of these, 5 million die and another 5 million are left disabled. Whilst most strokes occur in people over the age of 65, they can occur in much younger people too. But what exactly is a stroke? The brain, like all parts of the body, needs oxygen, which it gets from the blood. A stroke happens when blood flow to the brain is cut off. When brain cells are starved of oxygen, they become damaged, and the symptoms that follow are called a stroke. As the brain controls the whole body, the symptoms of a stroke can be wide-ranging, depending on which parts of the brain are affected. If the stroke occurs here, it would cause a drooping face, here, weakness in the arms or legs, or here, difficulty speaking. Other symptoms can happen too, like changes to vision, loss of balance, confusion, and memory loss. The effects might be barely noticeable, but are more often severe and disabling. Sometimes these changes can be reversed if treatment is started early. That's why it is so important to act quickly if you suspect a stroke. Remember, you need to get help fast. F is for face. Is their face drooping on one side? Can they smile? A is for arms. Is there weakness in the arms? Can they lift them both up? S is for speech. Is their speech slurred? T is for time. If you spot any one of these signs, then it's time to call an ambulance. Once the ambulance arrives at the hospital, a doctor will assess you and arrange an urgent scan of the head, which shows where the brain is damaged and what type of stroke has happened. Strokes are put into two groups depending on the problem in the blood vessels supplying the brain. There can either be a blockage, called an ischemic stroke, or a bleed, called a hemorrhagic stroke. The majority of strokes are blockages. It's important to identify early on which sort of stroke has happened, as they each have very different treatments. Blockage strokes are commonly caused by the buildup of fatty material in blood vessels. This fatty buildup may lead to a clot, which blocks the blood supply, just like in a heart attack. This is why a stroke can be thought of as a brain attack. A clot may occur within the brain, or it can travel from another part of the body, commonly the blood vessels in the neck. Clots can also travel from the heart, which may happen when you have an irregular heartbeat called atrial fibrillation, or AF. If a blockage stroke is detected within the first few hours, a clot-busting medication is sometimes given to dissolve the clot. This is called thrombolysis. If thrombolysis can't be used, other medications such as aspirin will be given as treatment instead. Bleeding strokes happen when a blood vessel bursts suddenly, causing blood to leak in or around the brain. In these strokes, blood on the brain can lead to swelling, a serious problem which may require surgery in some cases. Sometimes, stroke symptoms completely disappear in less than 24 hours. This is called a mini-stroke or TIA. Often, symptoms only last a few minutes, but just like with a full-blown stroke, you must go to hospital immediately if you suspect a TIA. This is because a TIA is a warning sign that you're at high risk of having a full stroke. Whether you have a TIA or a full stroke, daily medications are started and continued lifelong to help prevent further episodes. The effects of a stroke can be disabling, but given time, the brain can slowly adapt to recover some previously lost abilities.
Once again, welcome back to Elixir of Life. Our episode theme is rehabilitation after stroke, and to welcome my guest, Dr. Ahmad Al-Qureshi, consultant physical medicine and rehabilitation, and Mr. Faisal Al-Dubian, is a physical therapist. We'll continue our interesting discussion. The next question: what initial medical care will I receive after diagnosed with a stroke?
Yes, if somebody asks me what is the best stroke management, I would say prevention is better than cure.
Excellent.
But once the stroke has happened, in the world of stroke medicine, we say that time loss is brain loss. So if somebody recognizes the few symptoms of stroke or signs of stroke, they have to seek urgent hospital care or institutional care as well. If somebody notes down that there is any weakness of arm, sudden weakness of arm or leg, or sudden speech problems, or they really have to rush on to the hospital, to a place where they can get the best of care. So the reason is that because the stroke progresses, there's a likelihood of progression of stroke to an extent that it can cause death. In the United States, like after every 40 seconds, there is a person who's having stroke. Every 4 minutes, there is a person who is dying of stroke as well. The incidence of or the prevalence or the reports or data regarding stroke in Saudi Arabia is very lacking. They say like few of the reports are there. They are building up a stroke registry, but the numbers are saying that almost like 30 per 100,000 population per year. So coming back to your question about what is the initial management of stroke rehabilitation. Usually the patients are taken to an emergency and then they are transferred to a medical floor after assessment for medical stability as well. It is very important to control their blood pressure, their blood sugars as well, and to determine the extent of the stroke and to determine the kind of the stroke as well, because it's very variable. If it's a bleed, the treatment line is absolutely different. If it's a clot, the treatment line is absolutely different as well. And then the extremely important thing which starts from day one is prevention of another stroke, because there is a likelihood that you can have another stroke within the first few days, up to 3 to 6 months as well. So there are certain medications which are started for the secondary prevention of stroke. That means to avoid the second stroke from happening. And during the same time, the most important component is to make the patient aware, make the patient and the family of aware of exactly what's going on. Because we try to inculcate this idea among the patients and their family that stroke is not a disease of a person, of an individual. It's a disease of the family. It's something which affects the family and the people around them as well. So, and people have a lot of misconceptions about stroke and their outcomes as well. And not only after the initial medical care, that is a time where we tend to start when the patient is stabilized, the rehabilitation care as well. If the medical stability is achieved within 24 to 48 hours, that's the time we can start to prevent the complications of prolonged immobility, because every day you're losing muscle power, which is called, on holistic terms, it can result in deconditioning as well. Then contractures can develop, then skin breakdown can happen as well. And stroke itself can be very depressing, especially if the patient has cognitive impairment, thought process problems, language problems as well. They're not able to communicate.
Excellent.
Sometimes they know what's going on, but they cannot express themselves.
Excellent. And I think the timing of presentation to emergency is crucial, because if it is within 3 hours, patient can be given.
Yes, absolutely, and that's where the time loss, brain loss concept comes. It is very extremely important, and the leading stroke physicians in the country and the stroke team members are working on promoting this idea that as soon as somebody identifies the symptoms or signs of stroke, they have to seek urgent care. Why this concept is needed? Because the window period within which active intervention can be done is very less. There are some medical interventions that can be done, treated with some medications to thrombolize or dissolve the clot within probably 3 hours. Not all patients are candidate for that, but it can work very effectively.
It can reverse, okay.
Absolutely, and it can reverse many of the effects that the patients can have, especially within the first 3 hours. Then there's like up to 6 to 8 hours, some mechanical interventions can be done as well. The challenge in Saudi Arabia is that we don't have a lot of those facilities available where these active interventions can be done.
Okay.
Emergency services are there, but lack of awareness, the time passes by, the patient and the family, they wait on, and probably they spend like 6 to 8 hours by the time they reach the hospital. So the time of active intervention is lost.
Excellent.
So
beautiful.
Then we have to work on active rehab.
So time is gold.
Absolutely.
Okay. And I think this is leading us to the next question, that after diagnosis of stroke, where does stroke rehabilitation take place?
Actually, based on the severity of the injury, if it was mild or severe. For example, if the injury was severe, so after the assessment from the physician and from the physical therapy and the occupational therapy and other teams, so we decide if the patient needs to stay at the rehabilitation hospital or to continue as an outpatient.
Mm-hmm.
So if the patient was severe, so we advise him to continue in the rehab hospital, or if the patient was okay and fine and he's able to go or to stay at his home and to receive the care as outpatient, so we tell him to continue as outpatient.
Okay, so it could be inpatient and
outpatient.
Outpatient, yeah. Okay, but not in the emergency.
No.
Okay.
Yeah.
So when stroke rehabilitation begin?
Great. So we usually encourage, once the patient is medically stabilized in a hospital setting, we start off basic therapies to prevent the complications of immobility and to encourage mobilization as well. Because in the initial phases, there's a likelihood of clot formation too in the legs or in any part of other blood vessels of the body too.
So as early as possible, as soon as possible.
Yeah, early mobilization is something that we encourage as well. But of course, we need to take clearance from the treating physician at that point in time. Sometimes the patients have bleeding the brain and they require surgery. So that's the time you won't really push the patient because it can precipitate the situation too. Yeah, and many times we receive patients after many months altogether. So if a patient is coming after 3 to 6 months, the time of neurological recovery has probably passed by, but we can still work on the on functional recovery as well.
Excellent.
So, the goal of rehabilitation still stands there, which is empowering the patient by minimizing disability, maximizing functional outcomes, and facilitating neurological recovery. So there are many techniques used by all the disciplines, especially physical therapy, occupational therapy, and speech and swallowing therapy as well, to facilitate neurological recovery by using some high-tech equipment too.
So the recommended time as early as possible, and to maximize the benefit should be within 6 months. After 6 months, the effect or the benefit of physical therapy is decreased or absent?
This is usually a discussion which comes up with patients a lot. It's a very good question. Based upon the literature, science, and research, the maximum recovery time, maximum neurological recovery is within 3 months.
3 months.
So when we say that maximum neurological recovery is 3 months, it can also be interpreted that this is the time of the maximum gain from active rehabilitation or intensive rehabilitation as well, because the neurons or the cells of the brains they are reorganizing themselves. So Allah subhanahu wa ta'ala has made the brain in a way that if a part of the brain is not working or is damaged or affected, the part of the brain around it tries to recircuit it and tries to take the action of that brain, and that happens up to 3 months. They say maximum 6 months as well. But there are certain things which continue to improve, just like language problems, which is actually a problem where there's an inability to comprehend things, process things, and express things as well. That can continue up to 12 months and more as well.
12 months more.
Yeah.
So how long stroke rehabilitation lasts?
So it exactly varies about, as Faisal has mentioned, it varies about the severity of the patient as well. It also depends upon, what are the expected outcomes for the patients, because every patient is different. So people usually ask us, can I walk? Or can I go back to work? So we have to answer those questions based upon scientific reasons, not upon guesses as well. So there are certain poor predictors of outcomes, meaning that if a patient has advanced age, they have multiple illnesses, they have poor sitting balance, they do not show any hand or arm recovery in the first month, that means it's a poor prognosis for hand or arm recovery. Similarly, if they have visual deficits, that's a poor prognosis. If they have language impairments or cognitive impairments, they have poor prognosis as well. So based upon those factors, we usually ask this question that, what are going to be the outcomes? Coming to the point which we're concerned about is, how long does it take? So, for example, if there's a patient who has, let's divide it for general public convenience, mild, moderate, and severe stroke. Milder strokes may be coming up with slight speech abnormalities, but it's comprehensible. People can understand, but they have a little bit of, arm function deficit, or a little bit of leg weakness as well. So those patients are usually enrolled in outpatient therapies, but again applying the same principle that they can continue like 1 or 2 months of outpatient therapies, and then they can roll on into home exercise program in the local community. But if the patient has moderate to severe stroke, how do we determine that? For example, 50% of patients, they are fully functionally independent after stroke. 25% they require some kind of help to become independent, and 25% of the stroke, 20 to 25%, they remain dependent for the rest of their lives. So depends upon which kind of stroke you're dealing with. Typically, our inpatient stroke rehabilitation program is lasting for 4 to 6 weeks.
4 to 6
4
weeks.
to 6 weeks. That is a program depending upon the resources and flexibilities that we have. But if you're in the US, the average length of stay for stroke patients is about 15 days.
15 days.
15 days.
And in our hospital, or
in the United States.
United States, yeah. But what about our hospital?
It's about 4 to 6 weeks.
What's the reason? Okay, behind that. Okay.
Yeah, number one is that we have a much more resources in terms of time and time to be spent with the patient as well, as compared to many of foreign countries. There are many financial restrictions. The insurance is driving healthcare, and there is assigned time to finish up or achieve your targets. The other aspect is that what we are lacking terribly, we are lacking a lot in Saudi Arabia, is the community-based rehabilitation.
Community-based rehabilitation. Yeah. That's, I think, the most important reason.
So we want to benefit the patients as much as possible. Unlike in Northern America and Western countries, where the community-based or local rehab resources are really empowered, so you can discharge the patient. If the patient needs nursing care or therapies at home, that would be guaranteed and provided as well. They would have local rehab centers who will take care of all their needs, including social needs, vocational needs as well. Over here, we have those deficiencies. That's why we tend to give maximum time so we can optimize the patient care. Because if the patient is coming from far from areas, it's a kind of liability on us or responsibility on us to to make sure the patient is safe to be discharged home, or he or she has reasonable resources that they can go back into the community and start their life journey again.
Excellent, excellent. So let's a patient diagnosed with a stroke. Where can a stroke patient get rehabilitation? In any hospital in the Saudi Arabia, or there are certain hospitals?
Right. It's actually, I would answer back the question in the same way. If the patient only requires outpatient therapy, like for example, if they're like mild stroke, many of the hospitals and institutes in Saudi Arabia, all over the kingdom, have their basic therapy as well, like physical therapy is available most of the hospital. Then occupational therapy is there, but less. Then speech and swallowing therapy, sometimes they're there, but sometimes they're not. So the ideal interdisciplinary rehabilitation team model is lacking. It's very confined. Currently, it's confined to the main cities like Riyadh, Jeddah, Makkah, and the eastern areas as well. We are having a lot of challenges to develop this in the northern areas. We are having a lot of challenges to develop in the southern areas as well, because as you know, this is an area which is under a war zone at the moment. So we are having a lot of need. We have a lot of need for rehab in the southern areas.
This is unmet need, huh?
A lot of need, besides stroke as well. Yeah. But good thing is that the Ministry of Health is working along to promote this collaboration. The Ministry of Health recognizes this need, and they are promoting and transforming the health system, and rehab is an integral part of this transformation.
Excellent, yes. Yeah. I think it's, besides stroke rehabilitation, we have one of the highest countries in the world with the road traffic accident, a brain traumatic brain injury, spine cord injury. I think this is again adding, more need to highly specialized rehabilitation centers.
Absolutely. If you look at the CDC statistics, the trauma relates to 16% of the deaths. 16% of the deaths, which is reported by the CDC because of the trauma and the injuries in two different categories, which is a report on mortality deaths. So you can imagine the impact of trauma on morbidity as well, which actually results in disabilities, and patients usually don't know that even if you have a spinal cord injury or stroke or traumatic brain injury, there are resources available in Saudi Arabia. So there is a lack of awareness as well, and I think that needs to be encouraged from not only education level but at community and public level as well through the media.
Excellent. What do you think the future directions for rehabilitation or rehab medicine in Saudi Arabia?
I think it's very promising. It is bright. If you think of rehabilitation, as I said, like the Ministry of Health has recognized the need of rehabilitation, considering the impact and the weight of the need of disability care in the country. There has been a lot of investment going on. There are medical cities in which there are under development, in which there is a rehabilitation sections or rehabilitation hospitals with certain number of beds assigned for rehab. Basically, and the other thing is in terms of rehabilitation medicine, we are having a lot of applicants, a lot of young physicians, young graduates who are doing internships with us. It is, we are promoting this, and we have a lot of scholarship opportunities as well for these trainees to not only avail training opportunities in Saudi Arabia, but also to go abroad, because there is a dire need of local manpower who is trained in rehabilitation and rehabilitation medicine. Yes.
Excellent. What's the pathway for physical or rehab medicine? So is it after graduation of medical school they join? So it's a new, relatively compared to College of Medicine and Surgery. I mean medical and surgical subspecialty. So what's the pathway after graduation of medical school? What training they will go for?
Right. It is just like other specialties that they have to complete internship, 1 year of internship as well. And usually there is a requirement of SLE, Saudi Licensing Exam as well too. And then based upon the GPAs and their exam scores, and there are certain criteria which has been set by the Saudi Council, they can opt for the specialities which they want to prefer to train in. And if they want to train in physical medicine and rehab, which goes by the name of physiatry or rehabilitation medicine or PRM, physical and rehabilitation medicine, they can access the universities or hospital where their training is being done currently in Saudi Arabia.
Excellent. Thank you, Dr. Ahmed. Question for Mr. Faisal regarding the physical therapy for stroke patient. What the most commonly disabilities that you work on in physical therapy?
The most common disability with the stroke patient, most of the patients, they have weakness in the upper and lower extremity, on the right side or the left side, in one side I mean. So if that happened to him, if he has weakness in the other side, he might have some weakness in the, limitation in the ambulation, so he might not be able to walk, or he might have some difficulty while he's walking. He might need someone to assist him or to hold him while he's walking. Even he will have some difficulty while he is using the stairs or outdoor ambulation, outside his home. So after our assessment, we see what we can do with him. We set goals and we discuss it with the patient that we will do or we will work with these goals, and we will achieve it within, for example, 1 or 2 months. So our main goal probably the ambulation. This is the
ambulation is the most important.
The ambulation. Yeah.
And what are the measures should be taken to avoid fall?
To avoid fall.
Yes.
Yeah. The most important thing at the beginning, we start to educate the patient, even the watcher or the caregiver. We educate them how to prevent the fall. For example, not to walk in a dark area, to wear the shoes while he's walking, or to walk with under supervision. So we educate the patient and the caregiver to prevent the fall.
So that's important. Yeah, that's very important. And again, before we wrap up, we'll ask important question. After all you have mentioned, do you think that rehabilitation medicine or rehab medicine is a luxury or necessity, Dr. Ahmed?
I would say it's a necessity. It's one of the integral parts of medicine now. Probably it's one of the most beautiful specialties which is holistic. We're not only dealing with one organ or organ system. For example, a cardiologist may be focusing on heart or cardiac issues as well. Similarly, a general surgeon may look into a particular organ that he or she is operating on. Rehabilitation or rehabilitation medicine is holistic. We
Holistic approach.
Holistic approach.
Biopsychosocial.
Biopsychosocial model. Whenever we are dealing even with a patient with spasticity or muscle tightness in layman's word, we are actually looking at, we are visualizing his function, his or her function, and how that function can help him to go back to work. So, that's an extension of, that's the beauty of the extension of our specialty.
Excellent, very beautiful subspecialty.
Yeah, absolutely, and I would like to take a liberty to mention this over here for young physicians. It's not only limited to inpatient disability care. There are many interventions that a rehab physicians can do. For example, there is specialized training program in spine and musculoskeletal, in which rehab physicians are trained in doing epidural steroid injections or medial branch block injections, or dealing with low back pain problems.
Excellent.
Spinal cord stimulators. Then there's intrathecal baclofen pump and spasticity management.
I will talk about the spasticity management maybe in the next question, because it's very important. Now we're gonna go for a report. To watch more details about this report, please stay with us. Don't go away.
This is why stroke rehabilitation is so important. Rehab can be challenging, but many specialists are on hand to help alongside doctors and nurses. If your stroke causes difficulty swallowing, dietitians can recommend special diets or feeding tubes. If you have problems with communication, speech and language therapists can help. If it has become difficult to walk or perform daily tasks, physiotherapists and occupational therapists can offer exercises and home adaptations. Also, after a stroke, people often feel low or frustrated that they can't do the things they used to, and don't like being dependent on others. Counselors can help talk through these feelings, and many patient groups are available for further support. We've talked a lot about strokes, but what can we do to prevent them from happening? Even if you've already had a stroke in the past, there are many small steps we can all take to reduce our future risk of having a stroke, such as lowering high blood pressure, the #1 cause of stroke, stopping smoking, lowering cholesterol, being more active, eating healthily. If you have diabetes, keeping good control of blood sugar levels.
Once again, welcome back to Elixir of Life, our episode theme, stroke rehabilitation, and my distinguished guest, Dr. Ahmad Qureshi and Mr. Faisal Al-Dubian. We'll continue the discussion, and you mentioned earlier spasticity. Could you explain what's spasticity in a nutshell, and what should be done, management-wise?
Right. So spasticity in general terms can be explained as muscle tightness. If I have to explain it in scientific terms, I would say that the brain loses the voluntary control of the tone of the muscles. So there is an increase in the muscle tone when you move a joint a little quickly. It goes into tightness, and the muscles go into sustained contraction. That can happen very often. As I said, like 20 to 30% of the patients can have spasticity. The management again is very holistic, and we have to intervene very early, because the more it becomes chronic, the more it becomes permanent. There is associated pain, and pain is one thing. When the pain is incorporated in spasticity, not only function is affected, your sleep is affected as well. Imagine a person who has been having sustained contraction of his arms and legs. How agonizing could that be for that person? And if pain is associated with that, sleep is affected and mood is affected as well. So that chronicity of pain, mood, sleep, and sustained muscle contraction, that is very disabling, very a painful experience for the patient as well. So that's why we recommend to intervene as early as possible. The approach to spasticity is holistic. Many disciplines are involved in the treatment of spasticity. For example, going to the basic principles of, let's say, stroke rehabilitation. Medications cannot rehabilitate a stroke patient, right? There's a lot much more than that. So, in the treatment of spasticity, the first and foremost thing is, and a very important role of our colleagues from physical and occupational therapy in appropriately doing and teaching the patient and family the range of motion and stretching exercises. Then positioning is something which is often overlooked. How to sit, how to comfortably place your arm and leg in a position so the muscle does not go into contraction. Because if it goes into contraction, the likelihood is that it will stay in that position and a contracture would develop. A contraction is basically a tightness of soft tissue or even bony contractures can form, which can prevent the free range of motion of that joint.
Excellent.
Then there is a use of orthotics, which are devices which are used to prevent progression of this muscle tightness or spasticity, or prevent the formation of contractures too. Then there are certain modalities like electrical appliances or thermal appliances which can be applied over the muscles and joints to prevent this muscle spasticity from progressing. Then alongside this, you can imagine these are all non-pharmacological and non-medicinal use of treatment of spasticity. And then it comes to medication treatments. There are certain medications which act on the muscles itself. There are certain medications which act on the brain. The downside of those medications is because they can cause a lot of sedation and drowsiness as well. And if those patients have thought processing issues, mood problems, personality problems, those medications can interfere with the recovery of the brain too. Then sometimes if the spasticity is focal, meaning only one group or one joint of muscles is involved, we can use some injections.
Botox injection.
Botulinum toxin injections. These are injections in the muscles which can relax the muscles as well. But those botulinum toxin injections, I would like to convey this to many people who may be using this for muscle spasticity for many other reasons, that they will not be effective unless we merge them with other modalities of rehabilitation which we talked about.
Excellent.
And then there are if that doesn't work, then we have, if a generalized spasticity, we can use intrathecal baclofen pumps. There are some surgical interventions as well.
Excellent.
Which can be done.
Mr. Faisal, if you would like to reflect or add to what mentioned the role of physical therapy to spasticity, is there any measures to prevent?
Yes, regarding the spasticity, usually we do range of motion for the joint to prevent the complication of immobility for the joint, and even we educate the patient how to do the stretching and the range of motion by himself or by the caregiver, because if he didn't do any range of motion for the joint or the spastic side, so he might face some complication because he's not able to move it.
Excellent. We are coming to the end of our program. I would like you to give us concise take-home messages, okay, Dr. Ahmad?
Absolutely. Thank you very much, Dr.sheef, for having us over here. I'll go back to the same thing. Number one, time loss is brain loss. If you have any signs and symptoms of stroke, you have to seek medical attention as early as possible. If a stroke has happened, an intervention can be done within a short window period of time. So if we're not able to have that opportunity to intervene in that short period of time, then we have options of inpatient intensive therapies and outpatient rehabilitation as well. It's very important to focus on secondary prevention of stroke. I cannot emphasize on that more, which means that the illnesses which can cause the stroke itself, we have to look into it. There are multiple factors like diabetes, hypertension, cholesterol problems that have to be looked into, and they have to be very closely monitored and controlled. Also, some patients who have vascular malformations, they have to closely monitor with a neurologist. And certain patients, when the clot may be coming from outside the brain area, it may be coming from the heart, it may be coming from the legs as well. Some people may have blood problems or coagulation problems or bleeding disorders as well, so they are at high risk of stroke too. So these are the things that we have always to keep in mind.
Thank you, Dr. Ahmad, consultant physical medicine and rehabilitation. Thank you, Mr. Faisal, physical therapist, for enlightening us about very important topic, stroke rehabilitation. Thank you very much.
It's a pleasure. Thank you so much.
With that, we are coming to the end of our program. Thank you for viewing our episode. I wish you found it useful and informative. Until next time, we wish you a wonderful and pleasant time. Assalamu alaikum wa rahmatullahi wa barakatuh. Goodbye.